Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
A quick reminder before we begin, you can always send us your questions for Dr. Mingle on YouTube or LinkedIn, or you can send them directly to us in an email at hello@minglehealth.com. So, Dr. Mingle, a lot of our viewers have questions about digital strategy, and we're dedicating today's session to digital strategy.
Thanks, Kyle. And my apologies to our viewers. In my previous comments on digital strategy, I focused primarily on what's wrong with ECQMs. But there's a substantial value for you in your local digital strategy. Every high value practice needs one. Now, if your only goal in measurement is Medicare compliance, then ECQMs can be all that you ever need. But if your goal is high value care, that is quality, delivering everything to our patients that they need or should have, and its companion safety, which is avoiding all the things they should not have, and cost, which is doing it efficiently, you should have a digital strategy. Measurement should be routine, it should be comprehensive, and it should be built into your patient care routines. When I was in active practice, I was frustrated that I was unable to quickly access a list of my hypertensive patients, my diabetics, and any other category that existed, that still exists for that matter. I was excited and drawn into electronic medical records to at last enable a system that could give me relatively easy access to those lists. And likewise, I was drawn into measurement for those same reasons. This, I think, is where EHRs primarily differentiate themselves in the degree to which they support your digital strategy for measurement and your high value care. So I think it's time to rethink and refocus your EHR efforts toward your digital strategy. What does it take to optimize your digital high value healthcare? And I think the superficial list of that, the top three, is one, your EHR has to be capable of supporting your measurement system. Your documentation templates have to be rigorously built to put the data in your EHR that you need to measure your quality and safety. Your data collection and documentation workflows need to be meticulously defined, taught, and maintained so that you get the data into your system that you can recover and measure.
Okay, well, thank you for that overview, Dr. Mingle. So can you help me understand measurement using my EHR?
Yes, Kyle, great question. Measurement in the highest level is the relationship between denominators and numerators. Every measurement defines first a denominator. It's a set of criteria that makes patients or any patient eligible for a specific measurement. Every measurement is second defined by evidence of success. That is the numerator. It could be a number like a gold blood pressure or hemoglobin A1C. It could be an order like a prescription, a specific test, or a referral. Patients who are eligible for a given intervention are denominators. The intervention given or the results of that intervention is the numerator. It might seem at first that the terms denominator and numerator are impersonal, but they're not. They're highly personal. The list of characteristics that define what a patient is eligible for and what results or actions are taken on those eligibilities uniquely defines each person, as specifically as a fingerprint. You need to be able to identify from your EHR quickly and easily all patients who are eligible for any given intervention and the results of that intervention. It sounds simple, but it's no easy task. To get that data out, three things need to exist. One, the data has to be held in your EHR as structured data. Structured data is distinctly different than textual data. For text, you dictate or type it in. It can be misspelled, it can be misplaced, it can be neglected. In contrast, structured data is chosen from a list. Its location and syntax are standardized, it is unchanging. So when you're looking for a particular characteristic, you can always find it because you know where to look, and it is identified with unchanging language. The EHR needs to be structured as a database from which specific data elements can be searched and found. There must be a predictable and findable location for each data element that is recoverable with standard and available query tools. A query tool is the application and language that is used to recover the data. And finally, you or your designee must have access to that database and query tool. Many EHRs make the database and query tools inaccessible, often hiding it behind a paywall or building contractual language that prohibits advanced utilization of the data they hold.
Dr. Mingle, can you explain more explicitly about denominators?
Think about each characteristic you might need to know about a patient in order to treat safely and effectively. Demographics, which include age, sex, ethnicity, occupation, other social determinants of health. Vital signs like height, weight, blood pressure, temperature, and others. Family history, possible inheritable conditions, pertinent symptoms, pain, depression, pertinent physical findings like murmurs or other things. Active and past diagnoses and procedures, medications, allergies, immunizations, basically your standard EHR database and those data elements that exist. Those also think of it in terms of your pre EHR medical documentation. That complete ancient history and physical. It includes chief complaint, history of present illness, past medical history, social history, medication history, allergies. You know the list, and you can look at any dictation cubicle to find an up to date list. Each of these elements and others are needed to define all those desired denominator characteristics that you want held accurately and accessibly in your EHR.
Okay, so can you explain numerators now?
Any measurement, observation, or order is a potential numerator. They must be held accurately and accessibly in your EHR. If there's nothing else you get out of this set of discussions today, it's holding data accurately and accessibly in your EHR. Anything you do or order should be held in your EHR as structured data. Prescriptions or medication list, lab and x-ray orders, referrals. If it's instructions you or your staff are providing to patients, it should be represented as an order so that you can recover it, identify that it has been done. Note that many things can be either elements of the denominator or elements of the numerator, depending on your needs. For instance, a prescription for hydrochlorothiazide, a common blood pressure medication, might be a numerator of the measure indicating appropriate action was taken on a patient with high blood pressure. But it can also be a denominator element in a measure looking for patients who should have their serum, sodium, and potassium routinely checked with their kidney functions. So again, if it's there as structured data, you can recover it either as a denominator element or as a numerator element. And as we get more deeply into the care of any specific patients, those things that are numerators for one measure are going to be denominators for others. So, Kyle, I think that's a good start on the subject for today. In summary, reimagine your EHR as a source of denominators and numerators. At the same time, reimagine your patients as defined by those denominators and numerators. Think about the denominator elements that identify your patients who are eligible for any of the things you do or might want to do. And as you expand that list, engineer your EHR in order to hold that data in a structured that is an accessible fashion. Think about the numerator factors that identify your success. And again, think about how you hold those in your EHR to make them recoverable. Identify the documentation workflows that accurately post that data into your EHR, and identify the data tools that you can use to access and recover the denominators and numerators in which you are interested. This may be the one subject that you need to pound on the table to get your EHR to help you with, and it could be the best reason to change EHRs if you can't get access to this data. I know this is a superficial start. There's a lot more to it, and we'll get into a lot more depth and specifics as we continue into this series. Don't forget to share your questions specifically about these or other issues and your observations, how you've solved some of the common problems in using your EHR effectively.